Welcome to this podcast from the Medical Journal of Australia. My name is Sally Block, the MJA's news and online editor. The MJA acknowledges the traditional owners and custodians of the land in which we live and work across Australia. This podcast was recorded on the lands of the Wangal people. I pay my respects to their elders past and present. Breastfeeding is encouraged worldwide. It also has particular benefits for mothers in war zones. To speak about this and other interesting facets about breastfeeding is Dr Mariana Gutierrez Popoca. She's a paediatrician with Médecins Sans Frontières and visited the Australian Breastfeeding Medicine Conference recently. She joins me now. So first of all, what brings you to Australia?
Thank you for having me here. So Australia has a very good public policy in general for health. I am a doctor working with Doctors Without Borders. I'm a pediatrician, and one of my main focuses in my work is improving the way we support and promote breastfeeding in MSF, which Australia has been quite great at doing with their public health system approach. I think there's a lot that I could learn from the system in Australia, and although the contexts where we work are very different from the general health system here, there are things that we could be definitely adapting to use in our contexts. So basically, I came here first because there was a conference by the Australian and New Zealand Breastfeeding Medicine Network. It was for a couple of days in the first 2 days of May, and I was really looking forward first. Just hearing the expertise that has been developed in the region, having a bit of an overview of what Australia and New Zealand are doing regarding breastfeeding protection, promotion, and support, and also trying to network, creating some links with the regional expertise to see if there are opportunities for collaborations and if there would be any interest in supporting our strategies and programs to support, promote, and protect breastfeeding.
So, as you said, you're talking about the health system. General health system here is a good one. Are there inequities when it comes to breastfeeding rates around the world?
So, yes and no. It's an interesting question because across the globe there are difficulties bringing up breastfeeding rates. So the WHO and UNICEF have published recently in 2024 these statistics of percentages of exclusive breastfeeding from 0 to 5 months of age, because breastfeeding is recommended exclusively for babies from 0 to 6 months of age. So the WHO and UNICEF published these statistics from around the globe. Unfortunately, these statistics do not include high income settings, so we don't have representation from Europe, from the north part of America. Australia is not represented in those graphs, but globally what we can see is exclusive breastfeeding rates from 0 to 5 months of age are around 48%, which is really low compared to what the standard of care should be and what the WHO recommends. So, for example, the WHO worked in publishing the Sustainable Development Goals that should be accomplished by 2030. They had established that they wanted to increase breastfeeding rates by 2025 to 50% and by 2030 to 60%. And although it might sound like, okay, 48% doesn't seem that far away from that, this is a slow sort of like increase in the breastfeeding rates. In reality, what we should be aiming for are nearly universal levels of breastfeeding. And we see that the breastfeeding rates are pretty low in many countries, independent of the continent where they are found. And we see just a couple of countries that are excelling in breastfeeding, like for example, Rwanda has above 80% breastfeeding rates, exclusive breastfeeding rates in the first 6 months of life. But most of the other countries are struggling with getting their breastfeeding rates higher. Now, I do have to say that, for example, Australia, the numbers that I've seen from Australia are, although encouraging in the sense of, for example, in initiating breastfeeding, the rates of initiation of breastfeeding are really high in Australia, are up in the 90s, 95, 97%, which is very impressive. But sustaining the breastfeeding, the exclusive breastfeeding for the first 6 months of life is still a challenge, even in high resource settings like Australia, where public health is quite strong and where support is available for mothers and babies and families. So the breastfeeding rate in Australia drops to, I think, somewhere around 50% by 2 months, and then all the way down to 37% exclusive breastfeeding to 6 months of age. So I think we can all do better. We can all build up on those numbers, but there is a lot also to learn from each other.
How many deaths could be avoided in low and middle income countries if breastfeeding were to become more universal?
Yeah, so as I was saying, the WHO and UNICEF promotes the idea of near universal levels of breastfeeding because there is really not a lot of real contraindications to breastfeeding. I would like to say that breastfeeding is the physiological norm. This is how newborns and babies and infants are supposed to be fed. And scaling up breastfeeding to near universal levels would avoid about 823,000 infant deaths per year in low and middle income countries in the first 2 years of life. And I always like to talk about this number because there are not a lot of other preventive measures with this level of impact in child mortality. So when we think, for example, about things like vaccination, which is evidently really important, it's about 4 million deaths per year avoided in the whole world thanks to vaccination. This is again, when talking about breastfeeding, we need to think that this is the physiological norm. So if we were able to respect and protect the physiological norm, which is breastfeeding, we wouldn't need to be adding other factors to protect children, right? It would already decrease almost 1 million deaths per year in childhood mortality, which is huge.
So, on that note, how important is breastfeeding in emergency situations where MSF works?
So breastfeeding is important overall for any context in any place, but particularly in emergency situations, in the projects where we work, breastfeeding is an absolute lifeline. The fact that breastfeeding is way more than just nutrition. So it's kind of like the first immunization to the baby. The mother will transfer some of her immunoglobulins, some of her defense cells. Many of the components of breast milk are antibacterial, antivirus, antifungi in itself. Breastfeeding is a huge protecting factor against, for example, infectious diseases. It is also the perfect nutritional balance. It has everything that the baby requires up to 6 months of age. And then for the first year of life, breastfeeding is still the major component of infant nutrition after 6 months. It's really difficult to think, for example, in a place like Australia, a mom can absolutely take a decision because of various factors to decide that what is best for her and for her baby might be using a breast milk substitute and doing so safely. But unfortunately, in emergency settings like the ones that we work in MSF, this becomes absolutely impossible. There is no guarantee that the source of water is going to be clean. Very possibly, this family will not be able to afford in the long term an adequate breast milk substitute. Other foods and other substitutes may be introduced to this baby quite early in life because of the lack of the availability or the economical power to buy any breast milk substitute. The impossibility to have sterilization and good good hygiene around all the products to give the baby the breast milk substitute. It's a very complex situation, and when you have populations that are, for example, internally displaced, like many of our patients in armed conflict settings are, you cannot guarantee that they will be able to come back, for example, if they have any complications, if they present with any gastroenteritis, diarrhea, respiratory infections, which are the main risks when a baby is fed with breast milk substitutes. So this becomes an absolute lifeline for the baby, but it is also a protective factor for mothers. So it's not only about, obviously, the huge reduction of morbidity and mortality for children, but also it improves the health of the mother as well. It will protect her against breast cancer, ovarian cancer. It reduces the chances of postpartum depression. It enhances the bond between the mother and the baby. And in situations, and I think this is a bit, how do we say this, undervalued, in situations where you are in a very distressed context, where you are in a war zone, in a conflict setting where you're basically fearing for your life 24/7, the impact on the mental health of the mother is not negligible. It has a very big impact. We have heard some testimonies from moms in the Gaza region where they receive support for breastfeeding, and they speak so positively about the experience of being close to their babies, feeling that there is something that they can do to keep their babies healthy, to protect them from what is going on around them. So it's a very powerful thing. Again, it goes beyond nutrition, and in emergency situations like the ones we work in, it is the difference between having a child that will grow up and thrive and having an infant that unfortunately passed away.
That's a big difference. So what are the obstacles to breastfeeding, and how important is context?
Well, obstacles for breastfeeding come in various presentations. There is, I would say, it's a multi-factor sort of thing. There are, let's say, at an individual level, with this mom and this baby, the mother and baby diet, one of the big factors is whether the healthcare system was designed to keep them together or not. So, for example, we know that babies that are put to the breast in the first hour of life will have much better chances at a successful exclusive breastfeeding in the first 6 months of life. Just being able to put the baby to the breast in the first hour of life will guarantee exclusive breastfeeding for at least 2 months. And if those 2 months go well, then it's much more possible that this baby will be exclusively breastfed for 6 months. So already, for example, having these fragmented healthcare systems where sometimes the care provided is not it is not seen as a continuum of care. Different actors are providing the different parts of the care. So you may have one of the international organizations, I don't know, providing antenatal care, if there are any providing antenatal care in the region. Then you will have maybe, I don't know, the maternity is being supported by the Ministry of Health, but they are lacking supplies and they don't have a lot of resources. And then, I don't know, MSF took over the neonatal unit, but it's not connected to maternity. So sometimes when babies need to be admitted, they will be separated from their moms. These are the moments where this fragmented healthcare impacts a lot on whether breastfeeding will happen or not later for this baby. This can be, let's say, at the individual level of what happens to this mom and this baby. We have, of course, what I would say, like, it's the macro level, where we have, unfortunately, competing financial interests and very unethical behavior from the part of of the big formula producers. There is this thing called the International Code of Marketing for Breast Milk Substitutes, which is a standing recommendation by the WHO since 1981. It's not a how can I say this? It's not a legal document that enforces this to happen, but it's the WHO has been inviting all of the countries to establish policies and laws that will protect breastfeeding by abiding to the International Code of Marketing for Breast Milk Substitutes. So unfortunately, many of the countries where we work, there isn't any health policy. So just to put a bit of an example, because I think this might be interesting for people who have only been working in Australia. So Australia has certain policies and a legal framework to protect breastfeeding by regulating the marketing of breast milk substitutes. For example, it is not legal to do active marketing and commercials on breast milk substitutes, at least for newborns until 6 months of age. You're not supposed to see this kind of publicity or commercials, neither on TV nor on social media. You should not receive, for example, free samples of formula at your hospital be given by your nurse or your midwife or your pediatrician. Formula companies should not be able to contact health professionals and sort of ask them to prescribe this particular formula and then give them some sort of compensation for it, whether in the form of money directly or in the form of congresses or trips or things like this. And all of these things that are in place here, for example, in countries that do not take into consideration the International Code for Marketing of Breast Milk Substitutes, is non-existent. So as MSF, we feel a little bit sometimes like the salmon that is swimming against the current, because we have all of the marketing from the formula producers telling the mothers that the best thing that they could do is choose formula over breastfeeding. And we are kind of like the only ones saying, well, no, that's not correct. And this is very unethical. So that, let's say there are these factors hindering breastfeeding at a macro level. That's why within the work that we do, it's protect, promote, and support breastfeeding. Protect means really shielding the mothers and the families from this marketing, very aggressive and very unethical marketing that happens with breast milk substitutes. Then promoting is explaining to the families why breastfeeding is so important. So talking about the reduction in morbidity and mortality, all the risks that feeding with breast milk substitutes bring. And supporting is, well, now we have the mom and the baby. And as I was saying in the beginning, keep them together at the hospital. Make sure that the baby on the breast in the first hour of life. If this mom is having problems with breastfeeding, we should have trained staff that could help the mothers and support them through their journey in breastfeeding if this is what they have chose to do. So the obstacles are multi-level, and then at community level, what we are seeing is with the urbanization of the populations, some of the practices that happened naturally in the more rural communities that were very protective of breastfeeding are being lost, and then this is why we see more and more families and mothers is deciding to go for formula feeding, because it's seen as easier, more practical, something that you can do if the mom is working. It's seen as a solution to a modern problem, and many times it's disregarding the risks that it comes with. So again, it is very multifactorial what the obstacles for breastfeeding are, and they are extremely context dependent.
How is it that in some countries formula feeding is seen as sophisticated or a sign of economic status?
So I think this, again, it is very much linked to the aggressive marketing of breast milk substitutes. in it has done honestly an excellent work. One of the things that I learned from the conference was that producing a can of milk is really really cheap. Of formula milk is really really cheap, and 60% of the production costs are due to marketing. So they put a lot of their budgets into making sure that families think that this is the best that they could be doing. So you have on one hand the marketing of this product that should not be marketed at all. It should be available because you want to have the option when breastfeeding is just not possible, or when there are real contraindications for it. But it should not be something that becomes the norm and substitutes what I was talking about, the physiological norm that is breastfeeding, right? So in certain countries, what we have seen is that breastfeeding is seen as the sort of like the more economical option. And then, so if you do have the economical means to pay for formula feeding, this is what you should be doing, because these families have been convinced that formula is better than breastfeeding. Formula is not only not better than breastfeeding, but it is not comparable. Breast milk has all of these things that have been exclusively made for this baby and responding to the baby's needs in real time. Formula will never be able to do that. So unfortunately, this perception, this intense perception of society, one of the superiority of formula over breastfeeding, and two, not only let's say at a nutritional level, but also at a convenience level. Again, if you're a working mom and you're going to have to leave your baby for hours at a time, yes, you might want to have an option to leave your baby with someone else, and that this other person may be able to feed your baby. And again, this is part of the options and tools that we can provide to patients, explaining how can you guarantee that you continue to have a breast milk supply when you go back to work, when you're back into your other activities. But this is obviously very context dependent. And we do have, so for example, in certain countries, particularly in countries where polygamy is allowed for male partners, I have talked with some of our patients who say, I cannot start breastfeeding my baby because this is the only the payment of the formula is the only thing that is keeping the father feeling responsible for my baby. So if I start breastfeeding my baby, then the father may not feel like he's no longer economically responsible for the baby, and he might invest more of his time or of his finances into the second or third wife, into other children. So it's really complicated. It comes to a very complex situation where it's not just about, explaining the benefits of breastfeeding, that I don't like that term, but like I can tell you the benefits of breastfeeding, but if you're a mom in a dire situation where you fear that your partner may abandon you because they don't no longer feel responsible for this baby, I understand why some people might choose to go for the breast milk substitute.
So, what is the global breastfeeding initiative you are leading across the MSF movement?
So we have this initiative that started around 2019. We basically, it's an interdisciplinary group of advisors like myself. So I am a pediatric advisor working with MSF. So we have nutrition, sexual and reproductive health. We have nursing, midwifery, mental health, health promotion, myself, so pediatricians, of course. And we have all bear witness to the consequences of the lack of support, protection, and promotion of breastfeeding in our projects. We have all been confronted with the realities of receiving a baby under 6 months that has severe acute malnutrition And the cause of that malnutrition is the lack of breastfeeding, or the failure to support a breastfeeding mother. So it started in 2019 with all of these advisors coming together and saying we have to do something to become better at what we do at our level as MSF to ensure that breastfeeding can be uptaken if the mother wants to do that, to be able to accompany these mothers in their breastfeeding projects. And since then, there has been quite a few changes actually. So we produced a positioning paper where we urged MSF to put breastfeeding as a priority, because sometimes it's seen as something that doesn't need to be prioritized, or there is a false sense of well, this doesn't need support, it's a natural process, so any mother could breastfeed, right? Why do they need us? We came up also with a framework giving general sort of like direction to the projects to be able to establish better flows of care, to respect maternal and newborn diet proximity. And it has come a long way since then. And so the breastfeeding initiative is now working towards having a broader, what we call a roadmap. So basically establishing where we are now, what we think is not working very well, where do we want to go? So what the ideal would look like, and how do we go from where we are now to where we want to be? And that requires a multi-level approach to breastfeeding. So it's not only supporting, for example, the teams of clinicians that are directly in contact with our patients, so that they know how to support a breastfeeding mother. They know how to solve the most common problems, breast engorgement, mastitis, painful nipples, a baby that is not latching quite well, low breast milk production. That would be, for example, one of the layers of this initiative. But also going up to, for example, how do we support our female staff who might breastfeed at some point of their lives while they are working with MSF, right? So how can we make sure that HR reviews their policies to make sure that moms have a protected time to be able to continue breastfeeding? How do we make sure that our facilities are built in a way that is conducive to breastfeeding and to not separating the mom and baby diet? At headquarters levels, for example, designing a package of identification of poor breastfeeding practices in a community that put them at high risk of malnutrition for babies under 6 months of age. And this, for example, has to be adapted to emergency settings, right? So to explain a little bit what this would mean, because maybe for people who have never worked with MSF, this might be quite new. But MSF will sometimes launch an emergency team to go and do what we call an explo. So basically, they go to a region where for example, natural disaster is happening, or armed conflict is happening, or epidemics are happening, and they go and they do this exploration of what is going on. And one of the things that they evaluate during this explo is the nutritional status of the population, to see if there are high rates of malnutrition, because this is one of the things that obviously we would address as a humanitarian organization. But integrating, for example, breastfeeding within that first evaluation of the population would be very useful for us to have also an idea of what is the risk for these children to need support at some point. And since support for malnourished children differs very much depending on whether it's a baby still on a breastfeeding age or an older baby that you can already offer semi-solid foods, then it's really, this needs to be developed. So as a summary, let's say, the initiative tries to look to the entire MSF sphere and see how we can, again, promote, protect, and support breastfeeding at every level.
So how many countries across the world does that cover?
So the breastfeeding initiative, it's a global breastfeeding initiative. So it's actually intended to create strategies that will be adaptable to all the countries where we are working, where we will have activities attending to women or children, right? And just, I mean, because I think this number is very important. MSF, the percentage of patients in MSF that are pediatric patients, that are children, is about 69 to 70%. So that is a huge amount of our activities. So most of our activities will have a pediatric component. And the ones that don't have a pediatric, I mean, that are not specially focusing on pediatrics, are focusing on women's health. So sexual and reproductive health, maternities and delivery, antenatal care, postnatal care. So I would say most of our projects need some level of support of some sort of another with breastfeeding, and that means 70 plus countries. Basically, almost everywhere MSF is working, we'll be seeing moms, we'll be seeing children.
And when was this introduced?
So, as I was saying earlier, it started in 2019, although it has had its sort of like its moments of a lot of development, with things coming up, as I was saying, like the positioning paper that we published in 2019, or the framework that came in 2021, the something that we call the breastfeeding toolkit, that came up about a couple of years after. So there has been moments of a lot of development, and we are seeing, let's say, one of those moments of a lot of development since about a year and a half ago, when we started partnering up with another entity within MSF that is called the Innovation Partnership Unit, that helps people in MSF with complex problems, like, for example, how can we better support, protect, and promote breastfeeding, to design solutions for it. So that, let's say, new wave of actions started a year and a half ago, actually. Yeah, it was early 2025, the ends of 2024.
Can you speak to us about demedicalizing maternal processes?
Yeah, absolutely. So it's very interesting to think that a lot of the things that we do in hospitals to take care of babies and women are designed around the comfort or the convenience of the clinical staff, rather than what is actually best for this mom and this baby. I don't know, 100 years ago, when birthing was not so medicalized, of course there were terrible complications to women who would not have access to services, to emergency services, and birthing at home. But there are certain practices that we should be kind of rescuing from the millenary knowledge of women taking care of delivery. So I'm going to use a couple of examples that I think make a lot of sense with this demedicalization of maternal processes. So the first is, for example, the reason why women deliver or have been delivering in the last 50 years in a lying down position, like this kind of typical gynecology bed, where you will have the mother lying on her back with her legs up in this little stands. The reason why women started delivering that way is not because it's physiologically better or easier or has a better pelvic position to deliver the baby. It was basically because it was easier for a doctor to receive the baby. And that makes absolutely no sense. It's not helping the woman have an easier delivery. And another huge, let's say, example of this is how newborn care had been traditionally done for the last 5 decades, which was basically having the baby taken away from the mother, having a nursery that would be on another place, having the mother here, having the babies being fed with breast milk substitutes on a very tight schedule with very specific hours and things like this. That is absolutely not physiological at all. So I know, for example, from visiting Australia and from my my experience in some other high income settings, that there is sort of like a review of these practices that has happened in the last 2 decades, and where, for example, in Australian hospitals, obviously people are like, no, we're not separating mom and baby together. We're not separating mom and baby. We're not keeping nurseries where all the babies will be. We're definitely going to support breastfeeding. We're going to make sure that the baby and the mother are in the same space. But this is a practice that has not evolved everywhere in the same way. So it's funny because I feel like um, we designed our own problems with the way we conceived hospitals, particularly for birthing services, and for newborn care, with this separation of mom and baby. And later on, we realized, well, actually, that was not good, and let's go back to what was being done before, which was basically what would be done with traditional birth attendants in some rural areas where birthing processes have not been medicalized, where mom and baby are kept together very naturally. Again, not advocating for more home deliveries, but just saying that we also need to consider how these medical processes affect the baby and the mom.
And just finally, how important is it to support breastfeeding without imposing guilt or self-doubt on mothers?
So this is really relevant as a question, and I think one of the things that we need to consider as healthcare professionals is that we are here to accompany this mom and this baby in their project. This is not my baby. I'm not bringing him home. It's not going to be me who is going to be raising them. And I am absolutely convinced that parents will always take what they think are the best decisions for their children. Their decision making process is always influenced by what is best for their babies. Now, as a healthcare professional, my responsibilities lie on informing the parents about the risks of breast milk substitute feeding, about why breastfeeding is a physiological norm, what it brings with it, what are the difference between breast milk and formula. But in the end, it is my role to accompany them in whatever their project is. So this, let's say at an individual clinician level, as a health institution, as a health structure, what we need to be doing is ensuring that the environment does not disrupt or disrespect the mother and baby diet. So again, ensuring that we are not doing things because it's convenient for us, rather than it's because it's the best for the diet. And I think if we respect those things, then we are not imposing guilt on mothers. And about self-doubt, I think what is really relevant to mention is that the more the mother doubts about her capacities to take care of her baby, the lower the chances that breastfeeding is going to be successful, because this mom is going to think that she doesn't have enough milk, that she doesn't know how to feed her baby, that she's not prepared for this. She needs help. She needs someone to tell her what to do. And this is absolutely not what we should be aiming to do. We should be actually supporting the mother to feel as confident in herself as possible. And this requires also a shift in the way we think about our relationship with the patients. Again, not being there in a hierarchical position where I tell you what is best for you and I tell you what to do, but I accompany you through the process. And I might be able to help you with some of the challenges that you face in the way, but really you are the mom, and you are the one who knows this baby the best, who knows what is best for your baby, who has also all of the responsibilities, right? So I think having this approach would make a huge difference, and we could stay away from this guilt that can be imposed sometimes.
Thank you to my special guest, Dr. Mariana Gutierrez Popoca. You can find more podcasts on our website at mja.com.au or wherever you find your podcasts. Thank you so much for listening.